Good morning, everybody from New York. You can hear us and see us?
Yes, we can. Please go ahead, Annapurna.
Yeah.
Yeah, we've got a great panel here, and we look forward to your case.
Okay. So just myself, Dr. Annapurna Kini. Then I have Amit Huda, who is going to assist me in this case. I have two fellows, who is Prithvi and Krishna Wave. They have come here from India to get trained, and soon you'll be seeing them next year there in India Live, being faculty from Mount Sinai. So we are going to show you. The other question is, where is Samin Sharma, right? I think Samin Sharma could be right there in the audience. Is he
Yeah,
there?
yeah, 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 yeah.
How did he
Made
appear
it
here?
again.
How did he appear here? I think he paid something to the United flight pilot. Or were you in the cockpit?
That's it.
Yeah.
We made it. But really, thanks our Dr. Bahal and India Live organizers to give us the chance. This way, actually, I had done now of the 15, 10 times that was on day one there and day two late. We presented from Sinai. And I know the live cases are always a hallmark of our interventional meetings. And we are going to show two very interesting cases. And starting with the first one, Anu, start.
Show the slides.
Yeah.
Yeah, this is the case number one, who's a 76-year-old male who actually presented with a STEMI last month to an outside hospital, which was a right coronary artery STEMI. He had a PCI of the primary PCI. At that time, EF was 30. Subsequently, EF became 42 on good medical therapy, like you see what he's on. But we'll tell you, he continues to have angina, but more important, when you see the angiogram, we can see that during his STEMI PCI, other than RCA, he had significant disease of the distal left main, LAD, circumflex. So after he had the STEMI PCI, he was referred in that hospital for to be seen by the surgeons to have bypass surgery. But of course, patient wanted second opinion, did not want to have surgery, so came here to Mount Sinai for PCI. So if you see that the syntax score right now, residual syntax score is like a 22 with the left main disease. With that residual syntax score, which is intermediate, we decided a good candidate for PCI. So we're going to show you the angiogram right now. Then the question is, with that kind of a EF, should any kind of MCS assist should be taken, or could this case be done without MCS assist? So that's where we are. I'm going to show you the right coronary artery. That is where he had the stent. Everything looks okay. He's almost dual PDA, but small PDA has some disease. This is his EF now. Still has a
35, 40.
inferior 3540. The EDP today, sorry, LV gram and EDP today was like 14, well managed on the medication. So distal left main, he has a prox circ at the level of that OM1 origin, and you can see ramus, that is about 2.2 vessel, which is a significant disease in the mid. Then this is the LAD, which is mid to distal, again significant disease between diagonal D2 and D3, for probably a bridge way distal. This is where the residual disease, and this is where we are today.
Now see the caudal. We another caudal for the, because then we have to define now. Remember, for syntax purposes, although it matter less, this case already approved for, did not want to go for surgery. That basically, yeah, minor. That syntax whether 1111 or how. So the ramus was also 70%, and clearly the circ at the ostium may be borderline. So will be 111 and 0 may be circumflex. There is a disease in the circ distally. Now, question always comes that, of course, there is a very limited use of the assist devices beyond just balloon pump. But here in America, all the trials which are doing at present, anybody EF less than 50% and high risk anatomy like this case is being randomized into the trials, and they are comparing the many new trials, Superior, Magenta, and Picante, all of them against approved Impala, which is CP. So this case, because of that, I mean, can you do this case without using a support device? Yeah, can be. But remember, the here it always is that your procedure has to be 100%, no complication, no need for emergency bypass. And now for 2.5, 3 years, we have done about 12,000 angioplasties, and none of them have gone for emergency bypass because we need to take care of things ourselves. So that's why it is more of a protection rather than the necessity in this particular case, because EF got a little better, used to be less than 30% at the time of MI, then became around 40. Although today it looks like a little less than 40, but point of view, Anu, tell us now, continue your presentation.
Yeah, if we can
Yeah.
show the slides.
And then we'll have a discussion with all the
Yeah,
faculty.
this was the appropriateness. This is, we already showed, you know, the PCI of his, this was from
Outside.
slide. So the question, I think I just want to show one slide and then we'll go back, that which kind of intravascular imaging we need to use. So both on the ESC as well as ACCHA guideline, procedural guidance, we are talking about procedural guidance for complex lesion, which they are talking left main, bifurcation, long lesion based on various trial could be anywhere, anything, you know, 28 and larger. So there you definitely would do better if you use imaging. But in this case, which is a lesion severity assessment, okay, so it will become 2B, and that too, I think IVUS is preferred over OCT, especially when it comes to left main. And I think the number you need to remember is 6. Anything above 6 can be left alone. Below 6, something has to be done for the left main. But we have done OCT in this case, and we're going to show you the OCT.
Is that all right? We show the OCT now on this case?
Brilliant. Yep, we look
Okay.
forward to seeing it.
Good.
Okay, so this is
This
the one.
key is on our OCT.
Yeah.
Yeah, we use the Abbott OCT Ultron 2.0. So we start from the distal. It's a small vessel. It says the AI detected dotted line. This is the EEL. The start with the PUVAC 2.8 vessel, and this solid line is the lumen 1.9. Here, like a small plug, but if we come to the this is the level of the distal diag, then the plug start like eccentric, concentric plug. Some calcium is, but it's not that thick. We don't call it severe calcium, but diffuse lesion. If you come to the level of the this mid diag, then the lumen get bigger. So this white line to white line is 30 millimeter. But this PUVAC, it stopped at the level of the left main bifurcation because the total PUVAC length is 75. It's a long lesion. Actually, we did a second PUVAC from the circ. We can show it to the.
Yeah, show it.
Sure. So this is the second PUVAC from the circ. And actually, the mid lesion is very tight lesion, and come back to the osteum. This is the level of the left main bifurcation. Before that, so this is the distal left main, and area-wise, it's like 4.9. Of course, there's a discussion on IVUS or OCT. The difference is less than 10%. So considering even that, I think the area, even by IVUS, I think this is less than 6, the distal left main. So based on this imaging, we think this is a significant disease in the distal left main.
I can tell you OCT look less impressive than angiogram, right? Everybody agree on our panel? Because it's barely 6. Well, you see the angiogram, it looks definitely a much significant left main. I would know, beside imaging or no imaging, I would never, I mean, that's exactly for which patient want to be sent for surgery. I mean, there is a very significant angiographic left main disease, particularly at the distal area. Could it be?
Yeah, I mean, the interesting thing there is around, you know, the use of physiology or using an imaging adjunct to suggest physiological significance, I guess. And 6 millimeters squared, I know, is the mark that we use for saying it's safe above. In our consensus document a few years ago, we put 4.5 to 6 as a gray zone. Now, that was in many ways compensating for geographical disparities, particularly in East Asia. But in my practice, actually, where we have that question mark between 4.5 and 6, I do tend to turn to physiology. And the challenge there is also that mid-vessel LAD disease, which in my mind, although you had an MLA there of 1.7 or something, 1.7, 1.8, I would be wondering whether this procedure could be simplified. If you're committing to treatment to the left main, you might only have to treat the left main and avoid the distal LAD, mid to distal LAD. and their physiology for me would be more useful to
IFR.
No,
confirm.
yeah, no, that is true. So
What
I
you
think
want,
that's a very
FFR?
important point. And actually, in the Excel trial, when it was bifurcation, we made it clear also that don't worry about, FFR, IFR may not be that value. You go with the limit, with the
IFR is
IVAS, criteria,
FFR.
which is the 5.5 or 6. So I think this case for the mid is a distal. I think, in my opinion, mid should be evaluated later, but
Yeah.
first you fix the distal left main to the LAD.
Yeah, so if
Agree,
you want
because-
to do
yeah.
physiology, you have to left main first and then do the FFR or IFR of the
Okay, tell us what
distal
you have done
LAD.
so far, Anu.
No, what we did was the circ, we thought it was just a simple case, so we just ballooned it. And I mean, even angiographically, we thought the ostial circ could be left alone. Okay, because if ostial circ was involved and a left main LAD, then we are talking about a bifurcation at the left main. Now we know it's no bifurcation. We just took care of the LAD, circumflex, and this is where we are waiting for the panel to say what we do next. So circ looks very good. I've left the wire, even if we are doing the left main.
You want to go to epicranial view
I think
more or
I think
yeah.
Cath works.
Hmm.
Honestly, with this many complicated physiologic questions, this is, I think, ideal for Cath works, and I think that would help us tremendously. Another question I have: I don't know what the number is for OCT in the left main. I've
Yeah,
never
I know.
seen a lot of data.
Yeah.
But another factor here, even if it's say it is above the threshold, I mean, it does look worse there. I think there's a lot of plaque there. And if you have an 80% plaque burden, which unfortunately on this OCT, others you will, you don't really get the plaque burden. But I think that's another reason why I think I prefer IVUS in this situation.
So you're alluding to spectral wave potentially having greater depth, which is obviously
Yeah.
online now. The other consideration here is you've shown beautiful images from Ultron 2, but we're about to embark on
Doing
Ultron
that work.
3.0,
Balloon, what are you
which
gonna
will
do?
apply
Continue to do your work.
OCT-derived
balloon
physiology
on the
into
left
that
main,
LED
left main.
pullback, which might be of interest too,
Cath
in
is
line
pretty
with the
impressive.
Cath works.
I mean,
Cath works
Cath
has
works,
the
yeah.
angio.
Yeah, Cath works with such a highly evaluated company and with a Medtronic's affiliation. And we actually evaluated that, Jeff, a while ago. We thought that, knowing that so rely on our regular invasive physiology, we didn't pay much attention to it. But now I think it get another importance, knowing that it's really coming up many of these kind of cases. But in
Well,
this
we'll know in a
particular,
week.
yeah,
Also, a spectral wave also will have an angio FFR, which is actually quite fast, at least. So
Okay,
there's
cool.
a lot of solutions coming on board.
So are you
So-
planning to fix the LED left main first and then
Right.
see what's going to happen?
Down.
that's
Are we
it.
using some debulking device for the left main and LED, Annapurna?
But this is just a cutting balloon. Yeah. You go back and show, I mean, even the angiographically, otherwise, and what I think was a lot of lipid on the OCT. So we just cut it and we'll put a 4018 stent. What else? Then you want to do the FFR of the mid LED? Is that the plan? Go up.
First the stent, yeah. No, but what size cutting balloon is?
3.5.
Wolverine 3.5.
Yeah.
Remember the technique
Down.
of the cutting balloon?
Yes.
Do pull back, go back again at least 3 times, and leave it at least for 15 seconds, and so that is how you get the best outcome
Okay.
of
Got
the of new Wolverine, and go up to 16 atmosphere. Do not go beyond 20, because then it
Okay, down.
ruptures. Can go to 20, but it can cause a little
take
more
a picture.
dissection and maybe slight perforation, which we learned in the COPS trial. But 16 atmosphere is 18, 16 is quite safe, but few
Cool.
times, so that basically kind of cutting into the different
I think 18 is
area.
good, right?
So this
Okay,
is the
get us
And in
a
terms of
4018.
the first OCT run that you took from the LAD, have
Yeah.
you've selected as healthy landing zones as you could for that selection? You've mentioned an 18 millimeter stent. Is there any way
18
of
or
looking at
23.
the imaging again just to see where you're planning to land both proximal and distal?
Kiski, I mean, we are using our eyes, EYE eyes, and Kiski, based on his OCT, said what, like 16 millimeter length?
So
Yeah,
408
so
should be
because
good.
the initial pullback from
Right.
LED to left main, we missed the left main because the long lesion. But the normal landing zone to the left main bifurcation is 14. So 18 is gonna be the 4 millimeter in the left main. But the second
But
pullback,
you-
the left main lesion is just 5 millimeter or something. So maybe 18 is gonna be like side by side.
You could avail yourself of the dynamic display, which is actually quite elegant, which would give you all your locations side by side with your live fluoro
Yes.
and really simplifies the procedure.
And obviously, you can superimpose the
Go up,
information
right?
you've got
Yeah.
from withdrawal from the circumflex, considering you want at least a, I don't know what your
Enough,
shortest
enough,
pop
enough.
balloon will be, but certainly 6
Done.
millimeters in our lab would be the
Get us a
extension we have to
458
consider
or just
for
40?
proximal.
4.5.
The other thing is that I think the patient has
done.
tolerated this hemodynamically very well. And I think that the Impella may have not made a big change in this patient.
I mean, for me, we've been discussing this. CF actually today looks actually pretty good. I don't think it's 30. And for me, if the hemodynamics are okay, and I mean systolic blood pressure,
No.
someone like him who was a lower EF, I might consider a right heart cath. And I generally do that with Impellas anyway for weaning purposes. But I think up front, I would have just, if his blood pressure is 120 or 130, pulse is okay, not in any distress with an EF of 40, I think we could let it rest.
Okay, give me the FFR they want.
Had-
So
had you had a lower-
angiographically, we look at that. I was planning to post-dilate the left main. I don't think we need to. In fact, I think even
What is the
4
size? What's the size of the left main?
4 on the OCT is saying 4.5. We just
The
put a
EL
4.0.
is 4.5, but lumen is like
EL is
3.5.
4.5.
Yeah. Left main also has some eccentric plaque.
No need.
Well, I mean, you
Give me
can't,
the FFR.
if it's 3.5 and a 4.5, you can't tell if it's malopposed.
Yeah.
No, we are going to do the imaging anyway.
I mean, I assume you're going to pot, yes?
Do your proximal dilatation. Left main should be done with
Okay.
a 4 or 4.5. That's the question. Low pressure 8.
Look at, anybody seeing the proximal edge of the stent? It's almost ready to come out.
No, that's at the bifurcation level where the lesion was.
Okay, give us the
8.
4.
Yeah, call it 4. It's a 4 or 4.5. Called 4.
It's a 4.40.
4.
Okay. Because you are going to do
I think
imaging anyway.
without the pot inflation, particularly at the distal end of the bifurcation, the geometry of the stent potentially will mean lots of struts gathering across the circumflex, which is a reasonably sized vessel. So the pot obviously has two benefits for the audience in that it's going to overcome that caliber discrepancy between the larger proximal vessel to the distal main vessel, but it will also preferentially open struts across the side branch into the circumflex.
And there's maybe one more comment. Because if you look at the stent and the angio, it didn't look like it got the ostium of the left main. It looked like there is 2 millimeters to the ostium. So maybe overstretching it with a 5.0 balloon would also prolong the stent, as you have shown on the bench in clinical OCT data. So yeah, doing the pot may do all of these things. Yeah.
Down.
All right, so we are going to do OCT, repeat OCT, and then FFR for the mid LAD, right?
No, I think let's do the FFR.
FFR,
We'll do a OCT at the end, one OCT, right? If you want to stent it. If you're planning to leave it, then we do the OCT.
Okay. Yeah, angiographically looks reasonable, but yes, optimization will be done after the OCT.
You have the ready?
16.
Okay, down.
Right.
FFR?
Yeah.
Yep.
Okay, get the FFR wire.
And all these combined catheters doing a OCT or IVUS and FFR, they are the one will be the future for us. Rather doing multiple wires and technology.
Yeah, I guess the difficulty we have here is that at the moment, for instance, the OFR or the OCT FFR, as Abbott want to call it FFR OCT, it was VFR. It's determined by the length of the pullback, and we have a maximum pullback of 75 millimeters. And you've shown that in that LAD pullback, we couldn't get all of the disease in one image. So that's one of the potential weaknesses that we're going to have to overcome.
Absolutely.
With longer pullback and actually quicker pullback, so the proximal vessels will get visualized even in a long.
Yeah, so Ultron 3 will be a 1 second pullback, as you said. So it offers the opportunity both for use of saline and then potentially for extended assessments. I think it remains 75.
Yeah, when we think the OCT will come with the saline, not with the dye. I know a lot of people, some data people are putting up microcatheter. Yeah.
Ultron 3 is
Yeah, and Gentuity is another system that actually has a very rapid pullback and a longer length, so that facilitates saline. Spectrowave, I think, is also has a longer pullback potentially.
Okay, equalize quickly.
Take your other wire out. Yeah.
If you need it again. Okay.
Okay. Show the FFR on the screen. Yeah. Are we seeing equalizing? Yeah. Okay. Good. 1. All right. Let's go.
Are they showing the screen?
Yeah. Yeah.
Okay.
They're seeing. Let's see the prediction. Positive or negative? 0.8 or above? I think you're in the diagonal now.
I know.
Yeah.
I will change.
I think it will be negative. Jeff and Doran, what do you think, guys, and others who are on the panel? I know, but we are the names, but I don't know who made it to there. Yesterday also, when I was there, actually a lot of names on the panel, but like few % of people did not come, largely because of the travel. But still, it was a tremendous meeting. Such a large audience and great number of faculty, both national, international. And I know few people did not show up. I mean, faculty did not travel, but still, one of the best, and particularly area, right? Everybody agrees that Mandap is a phenomenal place for the meetings. Such a vast area and everything concentrated.
Yeah. Okay, start.
So this will be interesting to see, and then obviously it's critically important to undertake a pullback to get an understand of the profile in the vessel, and to check that we have effective equalization without any drift.
That's correct.
Well, I think we, sir.
Okay, so we have that showing. Adenosine has been started. Usually 140, or you want to make a double. 140 is okay. But many cases when things have done, we go 180 microgram per kilogram. But once it starts at 0.992, usually it's positive, right? What have been your experience?
Yeah. We always have that kind of question and kind of bet in the lab, but I have to say, until we've done the hyperemic response, it's very difficult to say.
I think there is some wedging of the aortic curve. So maybe put the guide catheter out, because there is a wedging of the aortic curve that underestimates the. Yeah, exactly. See?
Wedging is introducing a serial stenosis.
Yeah, exactly. Yeah. And I think maybe a repeat with injecting and then getting the catheter.
Here we go. Look at the FFR up there.
Getting to 0.8.
And we'll you're seeing a reduction in pressure and ventricularization of the distal waveform.
Yeah, guide is out now. Completely out.
Good.
Did you give the adenosine yet?
Yeah, it's going. It's going.
0.80. It got to 80 already.
Yeah, but you have to get a steady state.
That looks pretty steady, doesn't it?
Yeah.
Now.
Yeah.
The pullback will be interesting to just see exactly where we see steps, and then obviously to ensure that there hasn't been drift back at the level of the guide catheter.
So we're going to do pullback on non-hyperemic.
On
well, I mean, this we've now adapted to Coroventis and the PPG system, so we'd actually do the pullback under hyperemia, specifying that we're in the LAD.
You need infusion for it.
Yeah. So this is with I think an IV infusion of adenosine.
Yep, that's what it is. And here, so good.
Yeah, 1.0.
So it's 1. So it, went down to 0.80 to 81. Question is, do it or not do it? It's a plus minus. You want to?
I would leave it alone.
So we've just had a whole load of debates around strength of medical therapy and trying to avoid unnecessary stenting. I personally would be avoiding this.
Yeah. So and other question will be that in this particular case with a medium-sized vessel, that do we just do the again? This could be the case for the coated balloon DCB. Although as we know that here in United States is very expensive strategy. it is approved, but mostly many of the new insurance and Medicare fine, but others do not approve if it is not for ISR. So we had did trouble, but this case is a reasonable case if needed in the mid LAD that just do the
He's going to do it.
do the drug coated balloon. Yeah.
And where's the guide? It looks like it's
Guide is out.
No, we are.
Yeah.
No. We took
No,
out
we
the.
came out.
Like it's very
yeah,
wedged.
yeah.
Yeah.
Pull back.
No, it's fine. It just that is.
But I'll just say, in
yeah.
terms of the PPG, that would make sense. But I was advocating for the non-hyperemic in the US because there you can actually see, you know, how diffuse it is. And I think, I mean, if you found the PPG was high, you might be more tempted to stent it, correct?
I think angiographic. Yeah, do you do OCT or no?
We'll do a final run of OCT.
Yeah, let's do the final run of OCT, and then we'll get another case ready in our time, knowing that we did start at instead of 5, we started at 5:25.
Yeah.
We'll get another good case of with doing the OCT final run of the OCT. And
fantastic.
yeah.
In terms of the OCT, I mean, obviously there are important aspects that we want to be assessing here in terms of the optimization.
Yeah.
And for me, one of the things that still hasn't been adequately decided is whether kissing the circumflex is necessary.
That is true.
And so to streamline that, I'd be wiring the circumflex, going for a preferential distal cross, but using the OCT to reconfirm that. So do that all in one sequence. It saves you, it gives you the additional information without it necessarily coming at an extra expense.
And just maybe a question to discuss. Would you do a kissing in this case, knowing that the PCI to circumflex has been performed, and knowing that maybe in the future a re-intervention might be needing?
Yeah, that's a very good point. So I would say that in this particular case, the PCI of the ostial circ was not done. Remember that proximal lesion which was distal, that was stented. Nothing was done to the ostial circumflex. Now, question is, do you do a routine kissing? The question is with the ABC left main strategy, every case had a kissing, and or go with the Excel plan that if you have no disease in the ostium of the circumflex, just put a stent across. Cases where they did a kissing balloon at 4 years, there was slightly higher stent thrombosis.
Can you check the
So
clearance?
I think this is a big debate. But I know European, everybody wants to do a kissing balloon, and that was their the left main trial.
No good.
And cases with the stepwise. But we are here. I mean, we can ask everybody else, and now let's see what the ostium looks like. That if not involved, do you want to do a kissing or not kissing? That will be the issue.
Maybe we can try. 1 second.
Yeah. And don't go to the second lesion now. We're just doing a proximal.
Elevating.
Left main and proximal LAD.
Cine inject.
Yeah.
Yeah, great image. You got an image. Thank you. Second, doing the coagulation.
Yeah, so I mean, we are just recruiting a randomized trial of the IKISS trial, which is whether we need to, in a provisional left main LAD, to kiss into the circumflex or not.
Sure.
I can tell you, I'm a believer. I'm personally the believer of kissing.
We should have some.
Yep. I don't know what your personal belief. I know the data and so, but I personally do it, and particularly if there is any disease in the circumflex distal, like this case, where there was a stent placed, if there was restenosis, this case definitely I'll do a kissing in the end. And we can take the opinion what people want to do, but I will favor the kissing in this particular case.
Yeah, area is definitely well expanded. This is a distal left main area, is like 12, 13, like a small malposition here in the left main.
And you do a 4.5 balloon?
But I think it's minor because most important is the stent expansion, and already expanded to 12. And I know it.
No, but there is a little
malposition is correct, sir. It's correct, sir.
In terms of the acute malposition, it's more than 400 micron.
Yes,
and
it's more than
extends over more than a millimeter in length.
Yes.
The ostium of that
yes.
left main. So I would personally be looking to repot and importantly make another measurement at this point, because longitudinally you've got quite an eccentric left main there that may well be 5 millimeters in one plane and 4 in the other. So you may even have to go cautiously with a slightly larger balloon.
4.5.
But at the same time of that, I think here is where the 3D is really useful in terms of understanding the gathering of struts across the circumflex. And in some ways that can kind of inform you as to whether kissing is going to make a big difference.
Yep, let's make a 3D view now. Yeah.
So this is 3D view. So
we see beautifully that actually you've got struts
very
that have
nice,
fallen
yeah.
very well across the
Yeah.
side branch. Obviously, you can't dictate that, but
Yeah.
Yeah, it looks very nice. Yeah.
4, 5.
Are we ready there? We come there. Right. Good. So that's
Yeah,
it.
the
So
the
there was a
osteum
little
circumflex
small
is very
push.
nice in the stretcher line.
Yeah.
But I think that the
there's no link
proximal
across that, and it's fallen perfectly
So
right. I
that's a
think
slight
just leave that
malabsorption,
alone.
but
The
yeah,
proximal?
left main, like a,
Proximal.
yes, 0.46, like borderline. But most important stent is whether expanded 12. So it's gonna be discussion.
Well, I
It's
think
4,
though
5.
you have a stent in the circle which may need to be, so the left may need to be rewired
Right.
again,
Yeah.
sort of along the pot line. Also, you have at least moderate disease in the LAD, which may need to be addressed in the future. So
Yeah.
I think just in anticipation of a revisit, maybe we should optimize the inflow.
So other
Yeah,
question.
I think it's a nice demonstration
Mm.
because of the for any next procedures, I think those Malapose struts could be a place where a wire could go up luminally or where the guide catheter could
Yes, I
cause
told them
a
already.
deformation of
I
the
told them.
stent. So bearing that in mind,
No,
Paying
they
it
are aware.
forward.
There's no ongoing trial going on. I told them a trial also. Yeah.
Go.
So now question comes, knowing that it's a proximal edge and ostium is always little
16.
big, should we put a 4.5 Zion-Syscoy point at the ostium? Right? I mean, because there is a little wedging of the guide catheter at the ostium, and our current stent did not completely
Go ahead.
covered it.
18.
There should be put up just 4.5 stent, and that will just dilate. Although we are doing a 4.5 pot now.
Yeah. Well, I mean, you can put the Medtronic guide extension in there and give an injection and actually see the true ostium here if you want to resolve that as
Yeah.
opposed to guess.
Test.
yeah, both the telescope and the liquid have the ability to image through if you had to.
Go here also.
But I think, I mean, that's the eccentricity of a ostium to the left main that doesn't necessarily suggest extension of disease. You've got very good areas, even if it is disease. So I wouldn't place any further stents
Okay.
in
Good.
my
So
practice.
let's just take a picture here, and then we are ready for the next one, and then we'll complete with the last OCT, knowing that that area which where the stent was little
OCT.
malapose,
Let's get OCT.
we have done a 4.5 balloon now, and that should take care of it. Earlier was 4.0, 20, and to show the picture, Amit.
Yeah, we
Yeah.
just taking a OCT picture now.
Yeah.
Change the settings.
OCT, okay, sure.
Okay, another OCT run. All right.
And I think this is a step that's often overlooked, that
Okay, yeah.
people just in a
Ready?
rush don't
Okay,
bother
1 second, enabling.
repeating the imaging. So
1 second,
you have to be
calibrating.
commended on doing
Yeah,
this
Cine
because
inject.
you don't know that you've achieved the action you were looking to
Yeah,
without
great image.
having another look.
Yeah,
Right.
and the October trial really told you that when you treat the left main, you can get into trouble at the ostium of the left main, and that creates 2 times more events. So
Yeah.
I think it's a good idea to end with a good OCT and check the proximal part of the stent.
Because angiographically looks so good.
Yep.
Look at the angiographically looks so good at that time.
Yep.
So now we have the co-registration again, and let's see
Yes.
that area. Go to that area, Kiski, where
Sure.
it was malapose.
Profile looks
Yeah,
brilliant.
it's gone. It's gone.
Beautiful.
Yeah.
Gone. All
Well
right.
opposed.
So we are done with this case. We are ready for case number 2. Let's go live case. Anu is ready there, and we'll join there.
And dissection is covered. Nice result. MSA is 15. Great.
Well done, very nicely